There's definitely a lot of skill involved, and it's not something that most people can do. So unfortunately, there's a lot of people with some blobby lips out there.
I thought, my goodness, if you're going to do that and maybe host a party at your house, probably not having the infection control of your foot tattoo person, it's in the best interest of a person to get this done in a dental office.
The unpredictable thing in these anterior aesthetic cases is where the gum tissue is going to end up relative to the whole scope of things. The predictable thing is Dr. Pam's work, because she prepares the teeth, makes an impression digitally or analog, and then fabricates restorations. So we always want the unpredictable thing to be done and settled and checked off before we do the more predictable thing.
Get ready for your unofficial dental hygiene podcast. These are the tales of two hygienists, one East Coast RDH and one West Coast hygienist. Listen as they tackle the profession of dental hygiene with humor and enthusiasm. Now, please join Michelle Strange and Andrew Johnston as they tell you a tale of two hygienists.
Welcome back, everyone, to another episode of A Tale of Two Hygienists podcast, episode number 219. My name is Andrew.
And this is Michelle, and welcome to our little dental hygiene podcast. Also for the non-dental people, dental people, medical people, speech people, myofunction, any and everyone that wants to listen to this podcast. Thank you. Welcome. We're glad you're here.
We are so glad you're here and that you haven't been murdered by coronavirus yet.
Oh God, this is so right.
Can we start the episode by talking about coronavirus? Because I know how much you love it.
If you're hearing this, I'm actually probably on my way to Hinman. And if they cancel this, because there's been so many dental conferences already canceled.
That's where we should start.
Okay, I'll be very honest, though. I've seen more medical dental people not wash their hands properly in a conference center. So I'm kind of like, yeah, that makes sense. But at the same time, like, come on, guys.
Years ago, I made a post about this one particular like conference where I'm like, these dentists, and I know that they were dentists, would go in. They'd be talking on the phone as they're peeing at the urinal with their left hand, holding their business with their right hand. And then they would zip up. Hold on. Worse. Well, I don't know if it's worse. It's still disgusting. Then they would go over and just like spritz their hand with water and that's it. And then walk out. I'm like, why did you even spritz your hand? Like, what is the point of that? That does not make any sense.
Such a waste of time. I am actually really glad this is all going down. Because now we know that people are not wearing them. They're not wearing them properly. They don't even understand why they're wearing them. Did you catch that poll that I posted asking people if they would reuse their gloves?
Yes, I did see that. It was.
I'm just saying.
I mean, luckily, the results were overwhelmingly like no, and then like I would go home sick. And then
good.
Some people. Like,
but let's just. I'm just curious. Why are we picking and choosing the PPE that we choose that we will reuse and won't reuse? Like it doesn't make sense to me. His name is Andy. He works with OSAP now, and he asked me a really great question. I'd say this probably 3-4 months ago as I started getting into this whole infection control world and getting my credentials and doing all that stuff. And he asked me, if you had to practice with one or the other, what would it be, mask or gloves? And I was like, I feel like I need to say mask because of all the aerosols and splatter and stuff going into my mucous membranes, and I can't disinfect that. But God, the thought of me putting my hand in someone's mouth without gloves, I don't even want to put my own hands in my mouth.
Oh, right. I mean, even at home, sometimes when I'm flossing, I'll wear gloves just because it's disgusting and blah. But I want to say it's just a simple answer. Masks, 100%, like hands down. Like, how do you? But
no, that's not the case. Like, no one chooses that. I think we have this emotional bias towards it because of the years in the 80s too, with Hep B and HIV and the bloodborne pathogens that we have to take we should be taking every year. And I just feel like people are forgetting how you get sick. And if you do proper hand hygiene and you don't touch your face, you don't get sick that way. It's like you breathing in the droplets and the splatter and the aerosols, getting into your eyes, getting into your mouth, and hello, you're inoculated.
Right. You know, we had a patient this past week who, it was the most interesting thing because I on the one hand, I was feeling for them because they were very, very, very concerned about this coronavirus, right? So they come in and we have our touch pads for all of your electronic signatures. And they came up and they're signing in, very hesitant. Use the hand sanitizer right there next to the station multiple times. Request to go wash their hands. I wasn't watching, but I don't think that they use like a paper towel to open the door from the inside. So I don't understand how that part happened. That's just as disgusting to me. Anyways, so they came out of the bathroom. They were walking back. They were getting their radiographs done, and they asked for gloves. And so the rest of the appointment, they wore a pair of gloves. And it doesn't make sense to me, but I also didn't feel like it was my place to be like,
I
look,
know.
because in this particular sense, I didn't think that they would understand. I don't think that they had the IQ for infection control and dentistry and maybe life. I don't know. But for, to be able to comprehend and understand that wasn't really the problem. But yeah.
But don't you think that that's the more like dangerous side of this? I mean, hello flu, hello cold, hello all the things that we get upper respiratory infections constantly.
Right.
But I know plenty of dental professionals that still don't understand how they become inoculated and why they do certain infection control procedures and why you have to break the chain of infection at every chance that you get. And so that's why we wipe things down twice. That's why we wear a mask. That's why we don't reuse it. That's because there's no way that you can put that mask on and seal it to your face without contaminating your hands or your gloves. I just don't know how you do that. And so if you're just as grossed out by wearing gloves twice or putting your hands in somebody's mouth, then you should be as grossed out by a lot of things in dentistry and be doing them right. Because, well, the one thing that I keep telling people, it's not for you, because you'll see this too. And people were saying this in forums, and two things people were saying in forums that drove me absolutely bonkers crazy. One was, I've done this for 17 years. I've never gotten sick. Like, it's not about you. It's about the next vulnerable patient that's going to sit in your chair, or your colleague that doesn't have the same immune system that you do. Or you could be the carrier that takes this stuff home to your family and you never get sick, but they get sick. You forget about that. And then the professional that's like, oh, you're not going to reuse your mask? Give them my number. I'll come temp and I'll reuse that same mask while you aren't getting paid. Okay. Also, are you taking $12 an hour? I'm just like, where's the line where you are going to undercut your fellow colleagues? Like, what? Can we stop? It's so ridiculous. How about let's all just do the right thing, because BT dubs, CDC says we have to follow instructions for use. It's an FDA manufacturer's instructions, and those are laws, and you're violating them. So, and you're putting it on social media.
Yeah. Bunch of dum-dums. I wish we had time to go through all of them. And I wish also maybe sometimes this is a video podcast, because we could go through all the memes that we've seen recently.
Oh, yeah.
And show them. There have been some really clever ones. That
there have.
A lot of them have to do with the anti-vaxxers. And I'm sorry if that's kind of where your feelings are at this point. And no, we're not going to bash you on this particular episode, but oh my gosh. There's some good ones memes because of this crap.
I mean, if you have to find the silver lining out of any like politics, religion, natural disasters, like if you have to find some kind of like, go find the memes, because they're so good.
Yeah. Right.
You gotta have some levity in this.
As this episode is airing, I am actually heading to the Philippines. You're doing the Hinman. I'm going to the Philippines. Right. I would like to see on my way to Asia what the mask situation looks like, because honestly, that is one of the things I actually did learn through all this hubbub was, the lifespan of a single-use mask. I would have assumed that for at least a couple of hours, that would have been good.
You mean like when we're not getting it wet from the outside, right? Like as a provider.
Right.
Yeah.
But if I'm on a plane for 12 hours, like how long is that mask?
Well, that's the thing, is a lot of people are mouth breathing. They're getting it wet from the inside.
Right.
So yeah, it doesn't last that long. You got to read the instructions for use. And most of the time it's 60 minutes. And a lot of these are level 1 mask. And so I don't even know what you're
I'll be interested to
that.
See like how many people are wearing them for the duration of the flight. So I think it's a 12-hour flight over to Taipei. And so
are you going to, now the thing that I can get down with is the wiping of the surfaces, hand hygiene, obviously. breathing through your nose, letting your body filter the way it should. Maybe wear your nose filters if you're feeling crazy. But outside of that, I'm like, stay hydrated, take care of your body, because quite frankly, you and me getting coronavirus, we're going to feel like crap, but we're not going to die.
Yeah.
People getting all crazy.
Should we transition into some listener feedback? Some iTunes reviews? Okay. This one, sorry, everyone, we are a little bit late on reading some of these, but we had this one, I think it was when we were traveling to Chicago midwinter. It is from Micah B, 5 stars, invaluable info. And they write, I have been meaning to leave a review on my favorite dental podcast for years now! ! Hygiene school gave me the means to pass my boards and become a proficient licensed hygienist. Michelle and Andrew's highly curated content, passion, and guest speakers truly lit my fire for the profession of dental hygiene and beyond. The knowledge they equip their listeners with is not only elevating the profession, but ultimately allowing the best care to be provided for the patients on the receiving end. And I am encouraged to want to do better and be better, even though I constantly feel overwhelmed by all of the things I don't know and how to apply it daily. LOL. Thank you for your unprecedented and tireless contribution to the dental hygiene field.
Trust me, we feel overwhelmed all the time too. You're not alone. That's great.
Yes. Thank you, Micah. I appreciate that.
Yes, seriously. Well, I'm excited for this week's topic. It was kind of fun. Dr. Pam Maragliano-Muniz is back on, and she brought 2 of her friends. One is a periodontist in the area, and one is a high school friend of hers that does tattoo work. Because we're going to be talking about tooth trends, and one of them being the mouth tattoos. That was another one that I did as a poll in one of these forums. And I think about, by the time I looked last, it was over 1,000 people that have seen mouth tattoos. Have you?
Yeah, multiple times.
I have not. I have not seen it yet. Not popular apparently where I'm at. But so we're talking tattoos, tooth gems, which is kind of a new thing. Ivoclar has them out now. We just saw them at Chicago Midwinter called Skice. And then we're talking quote unquote gum reshaping, what I've always called gingivectomies or gingival recontouring or something like that, or even crown lengthening in some ways. And Dr. Tom Sterio was doing the gum reshaping. He also talks to us a little bit about the fillers and the papilla. So it was really a fun episode, and we hope you guys enjoy this topic all about tooth trends.
Hey, Michelle.
Yeah.
It's time for the interview.
Oh, but I had something else to say.
We need to let the experts talk now.
Fine.
So listeners, I think this is going to be a really fun episode. I always appreciate a round table, and I think that this is a fun topic. So I was really interested in some of the trendy things that I was seeing in the non-dental world, especially on social media, and then hearing randomly from my dental friends. And the first of those was going to be mouth tattoos. And so before we get into it, though, I want to introduce our guest. I'm going to start with Jamie. Jamie, welcome to the show.
Thanks for having me.
Tell us a little bit about you.
Well, I'm the owner of Forsaken Ink, and I've been tattooing now for about 16 years. Tattooed in this country, North America, Europe, China, Australia. It's taken me all over the world, and I have seen a lot of interesting things over the years. That's for sure.
I feel like that could be a whole episode on its own.
Probably.
And then a returning fan favorite, Dr. Pam Maragliano-Muniz. Now that I know how to say your name, I just like to say it.
I noticed you just showed that off. I love it.
Welcome back, though.
Thank you.
So tell us a little bit about yourself for those people that might be tuning in for the first time.
Sure. Hi, everyone. I'm Dr. Pam Maragliano-Muniz. I'm a dental hygienist-turned-prosthodontist, and so I own a practice in Salem, Massachusetts. I am the editor of dentistryIQ.com, so you might be getting emails from me periodically. And I write and I lecture and I get to do podcasts, and dentistry is really a hobby and a job.
And then Dr. Tom, do I say Sterio? Sterio? How do you say?
That's correct.
Sterio? Excellent.
Pronounced just like stereo system, but spelled with an I-O rather than an E-O at the end.
That's excellent. So tell us about you.
So I am 39 years old. I've been in private practice, practicing periodontics for just a shade under 10 years, and I'm one of the 3 owners of a large group practice. So we have, there's 3 partners. We have 6 periodontists and 7 dentists total, one orthodontist in our practice. We have 4 locations in and around the Boston area, and we have about 55 team members. So comprised of hygienists, assistants, and front office people as well. So it's a larger group practice in the grand scope of things in terms of periodontics practices. It's one of the to believe the second largest in the country. So we're very lucky and to be working with great dentists like Dr. Maragliano-Muniz, and look forward to talking with you today. So thanks for having me on.
No, this is going to be great. So I wanted to tackle the mouth tattoos first. And so I think I started seeing this or hearing about it, or at least seeing the social media pictures, I would say just within the last few years. But I did a Facebook poll in just one group that I'm in. So I can't even imagine what my other responses would have been. But I just wanted to tell you guys, let's see, I had over 1,000 people say they have seen mouth tattoos, which I was shocked by that. Only, let's see, 270 said no, and 9 said, is that a thing? and I was like, yeah, I think I've personally never seen a mouth tattoo before. Pam, Tom, have you guys?
I've seen one, and it was a younger patient who came in. He had done some traveling over and spent some time abroad in Ireland. He was coming in for a soft tissue grafting procedure on his lower anterior. And I saw this big blob of black across his mucosa. And I said, what is this? He said, it's a tattoo I got when I was abroad in Ireland. And it's supposed to say USA, but it had all bled together and turned into a giant blob. And his mom was sitting in the room just shaking her head. So I thought that was pretty funny. So the other one that I've not seen, but I knew I was coming on this podcast tonight, and I was talking to my assistant, who's a hygienist as well at the practice. And she says she has a patient with a boat tattooed on his attached gingiva, and the mucosa actually is tattooed as blue water. So the water actually moves as the mucosa moves. And she said that one was actually pretty well intact. So 1 out of the 2 mouth tattoos that I've encountered has been successful.
Jamie, have you placed or seen or had any involvement with mouth tattoos?
All of the above. Yeah, I've definitely seen some interesting mouth tattoos, everything from lips to people trying to tattoo gums and just tongues, everything, you name it. Like Tom was saying, most of the time they don't hold up very well. Usually it's just like a blob, but every once in a while you get one that's pulled off pretty good and it actually stays surprisingly.
What makes
typically
it
they don't stay that well.
Stay? What
Honestly,
is it? Just how deep it goes?
It's not so much how deep it goes. It's more of technique on how it's put in because of the angles. When you have a tattoo needle, they're not a solid needle because of the groupings. When they're stacked on top of each other, they kind of act like a fountain pen. So that's how they transfer the ink in. In order to achieve that crisp, clean line, you need to have them perpendicular to the tissue. Any variation in angle is going to have it bleed out and spread, like we were just talking about. So it's definitely a lot of skill involved, and it's not something that most people can do. So unfortunately, there's a lot of people with some blobby lips out there.
Jamie, do you notice any part of the mouth is more predictable to tattoo?
It's all pretty rough. It's all a crapshoot. I mean, oral hygiene plays a huge part in, of course, healing the tattoo. Typically, a tattoo anywhere on the body takes anywhere from 4 days to about 14 days, depending on hygiene and how healthy the person is. But mouth tattoos heal up extremely fast.
That would make sense.
Yeah. And I just saw one picture of one on the palate, and I was like, I don't know how people tolerated that, or the tattoo artist actually did it.
Yeah, you get to be pretty inventive when you're actually putting things on there and working in such a small space. Typically, we have to stretch the skin taut. This way, the needle punctures and delivers the ink the way we need it to. So if it's not, it kind of acts like almost like you're drawing on a pillow. It's really difficult to get the correct saturation, the correct angles. So, for instance, for a lip, we'll either, wrap it around a pen or a pencil or something like that that's been wrapped up to give it a little firmer of a base.
What do you do about saliva?
Well, usually if we're tattooing that close, we'll have a paper towel wrapped around our pinky finger. So we'll kind of rest and use that paper towel as a dam to kind of keep our area dry, because once that stencil goes, boy, it's gone.
I can imagine. So I'm curious about any chance of infection. You said it heals pretty quickly. Have you ever seen any get infected? And like you said, if oral hygiene is kind of a big deal, are there people that you're like, no, we're not going to be able to do this because of their poor oral hygiene?
Usually it's probably the easiest tattoo to heal out of anything. I mean, you just brush your teeth twice a day and you're pretty much good. But, we encourage people to use like biotin products like that to help kind of clean the mouth out and make sure that the bacteria is kept to a minimum. As far as their personal hygiene, if they're that dirty, we'll tell them to go take care of themselves before we're going to work on them anyway. It's kind of gross. Just begging for an infection at that point.
Lock the door behind them.
Yeah, exactly. Close for business. Sorry.
I'm actually curious too, Dr. Pam and Dr. Tom, do you think there'll be any issues in the future for these blobs to hide pathology?
I would think there's definitely a potential for it to hide pathology. And I guess depending on how inventive you are and where they are in the mouth, coupled with other risk factors, absolutely it could hide pathology. But I guess just like anything else, it comes down to the patient interview. So if you see this big blobby blue-black thing that you think is this large, huge nevus or something, probably once you have a conversation with the patient and you hear that they did this at a bachelor party 15, 20 years ago, I think you could probably deduce pretty easily that it was a tattoo versus pathology.
I agree. No need to biopsy the blob if that history comes to fruition.
Well, what if someone tattoos, let's say, something crazy on their lower lip? I mean, can you cut that out? How do you get rid of these things?
You would treat it much like you would. You've heard of an amalgam tattoo. It's a leaching of the amalgam into the tissue. The signal for the epithelial expression comes from the underlying connective tissue, meaning if you can take off the outer layer of tissue, the epithelium that contains the said particles, the tattoo ink, the amalgam, then it should repopulate with fresh epithelium not containing whatever was there previously, the foreign object. So yes, you can, but it depends on how large the area. If it's on mucosa, you'd have to remove a large field. I would imagine the best way to do that, if you're talking about removing the tattoo, and perhaps our tattoo artist could elaborate on tattoo removal extraorally, it would be probably done with a laser, and it would scar into a certain degree. So the tattoo would be gone, but what's worse, tattoo or a big epithelial scar on your mucosa that's supposed to be movable tissue. That's what you'd have to debate. So I guess it depends on what it said or how important it was for that person to get the tattoo removed.
Yeah. Well, one of them that I saw on the Facebook forum was a swastika. So I was like, maybe let's hope that somebody would like to remove that.
Correct.
Later on in life. But there was a lot of offensive words. Jamie, have you seen any, or do you see a trend in what goes in the oral cavity?
Yeah, there's definitely a trend there. I mean, it's not typical, and usually, like you said, it's usually like that spur of the moment bachelor party shock value type of thing, and that really doesn't have a place, and they're pretty few and far between. It is what it is. We all roll our eyes when they come in, but fortunately, they don't come in that often. And as far as the lasering goes, I think that would be absolutely disgusting. I don't know if you guys have actually seen laser tattoos, but they get blistery. Imagine having a mouthful of blisters. Oh, God, that would be terrible.
Yeah, I have seen a few. My friends have had a few of those lasered off after their 18-year-old. They turned 18 and had some alcohol somewhere in like Savannah for St. Patrick's Day or something.
I feel like I'm noticing a trend here that if you just make good choices to begin with, maybe you don't have to get it removed, or maybe don't get something that's that offensive, or just leave it there once you make the choice.
Pam, you are the voice.
That's why you paid attention in high school.
I did.
Well, are there any other things that maybe I didn't ask, or do you guys have any questions about mouth tattoos, or even do you do lip tattoos like for makeup and stuff? I know that's becoming trendy.
No. Yeah, they're doing a lot with the permanent makeup. I personally don't. I got into it more for the artistic side of it. Mm-hmm. And granted, there's a certain artistry that has to be done for that, but that's not my cup of tea. So I definitely didn't pursue that route.
Don't blame me on that one. Just painting lips Jeremy, on all day.
How much does a mouth tattoo cost? And is there anything that you would not tattoo on someone's body or in their mouth? What is your limit?
Oh yeah, I definitely. Well, nothing offensive racially or whatever. I just go somewhere else. Chances are, if you want something like that, go to some guy in his basement, because that's where you go anyway. A lot of stuff like that, it's just it comes down to a moral set. And a lot of people will do things that a lot won't. And the racial stuff we won't do. You got to draw the line in the sand somewhere.
How much does it cost though? Like, what's a good range for a mouth tattoo?
They're actually a little bit more, generally speaking, because they're more of a pain, and chances are you're going to have to come back, and they're gonna need touch-ups and all that. So typically the prices vary. For our shop, it varies by artist. We charge hourly, and the different artists, depending upon a lot of variables, charge different rates. A lot of other shops tend to charge by the piece. So the places that these guys are going to get those spur-of-the-moment tattoos will probably go to those one and done shops where it could be anywhere from $40 to $100, or it depends where they go.
$100. That's actually not as bad as I thought it was going to be. Any
turns
other little things that
I those tattoos in the past?
Yeah,
what's that?
Right.
That it turns out she's been overpaying for all her mouth tattoos in the past.
How about you guys? What kind of tattoo experience do you guys have? Do you guys have any?
I have.
Are we seriously going there?
I think we should go there. So let's hear it, ladies.
I have one.
Is it dental related?
Surprisingly, no, it's not. It was kind of a spur of the moment thing. It was one of those things where I was in the Jersey Shore with my family. We just had dinner, and my dad was pushing my brother to get a tattoo. And I was driving, and I just turned to him and I said, "Why aren't you asking me to go?" And he just said, "You're really going to get a tattoo?" And I said, "Yes. In fact, I'm in the market for one." And so nobody believed me. And so in order to prove that I was, in fact, in the market for a tattoo, which I was not in the market for a tattoo, was to get one. So I picked a purple cat, and I have a cat on my hip. That's purple.
This could be on an episode of Modern Family.
I know. Thank you, Jamie, for bringing this up.
This is great. I love that. Tom, do you have any tattoos?
I don't, but I heard that you have 3 just a moment ago. So please tell.
I do have 3. I have one white tattoo on my wrist, which when I went for the tattoo artist was like, "Why are you so stupid? Don't get white tattoo or white ink." And I was like, "Listen, you have a tattoo on your face. So I understand that you don't get why I want to be discreet with my tattoo, but it's just have faith, and it's white and it's already gone. Like, I'd have to go get it touched up." And then I did get a tattoo in someone's kitchen on my foot. And ooh. I will say their infection control was impeccable. And I would say it was probably better than some surgical offices I've worked in, which is why I was like, I can get down with this. And it actually lasted pretty, let's say like 6 years now. It's not so bad. And then I have one on my rib cage, which is in my grandfather's handwriting and my grandmother's handwriting. And it's the coordinates of where we all grew up. So those are what I have.
That's so sweet. Much better than my Jersey Shore cat.
And I didn't get any of these until I hit 30. And then I was just like, I want all the tattoos now.
So happens once you get one. Pam's an anomaly
than I thought I would.
Well, I know this is kind of the blending of all 3 of my lives. And so
it is.
Yeah. I should have known that some skeletons would come out.
Oh, I love it. I love it. That's why I love Round Table.
Absolutely.
I would love then to talk about tooth gems, and that being a new little trend. where we're adding some bling, which I'm really happy to be migrating away from grills. Really happy. And so, Dr. Pam, you have one of those.
I do. Well, I can tell you it started a few months back. My office is in Salem, Massachusetts, and Salem is known for the Salem witch trials. And in the month of October, we get so many tourists that a lot of my local patients, if they have to drive and park, they don't want to come in. Just inherently, my schedule lightens up in October. So this has been going on. I've had my practice for 5 years, and we just kind of decided if we can't beat them, join them. Let's do something that perhaps a tourist might want to do. And so we decided to bring tooth gems into the office and just said, you know what, let's see what happens. People can walk in, get it done. That's just how it's going to be. And then I started researching it a little bit more, and you could go on to a very common, large online retailer and buy your own kit and apply them to yourself as a non-dental professional. So I thought, my goodness, if you're going to do that and maybe host a party at your house, probably not having the infection control of your foot tattoo person, it's in the best interest of a person to get this done in a dental office. And so I figured I would just offer it up, see what happens. We had a handful of people come in. And then shortly after that, I just kind of stuck it out there and I put a picture of a tooth gem on Instagram, expecting to get destroyed by the dental community. And in fact, everybody was like, wow, that's so cool. That's so awesome. It's so neat that you're doing that. And I thought, well, you know what? I really can't think of a better place to bond a little gem to somebody's tooth, because at least we're offering a little bit of a cursory exam, making sure that the tooth structure is sound, you know, and hopefully encouraging people, if they're not getting routine dental care, to make sure that they are doing that. So it brings people into an office that might not be there otherwise.
To put a tooth gem on, I'm assuming you have to etch and like an ortho bracket. Were the kits coming with etch?
They come with etch, they come with bond, they come with flowable gems and a light.
Well, they got home kits for everything, don't they?
Yeah.
I guess so.
Oh my God, I'm so scared for everybody's eyeballs. I can just see them like staring at the blue light and then just putting acid somewhere that it doesn't belong.
Exactly. It's scary.
Oh my gosh. So what are some issues with putting a tooth gem on tooth structure that is not sound? I'm assuming like hypocalcification or early incipient lesions.
I would absolutely only consider a gem on completely intact sound enamel. Obviously, it's not going to bond to a crown or a veneer or something like that. And if there is hypocalcification, I don't want to etch and kind of cover that up. If it needs to be restored, then obviously the patient's tooth needs care. And then obviously if there's caries on the tooth, I wouldn't mess with it at all.
Are the gems just like a one little sparkly bling, or is there other things that you can be putting on people's teeth now?
There's a lot of things you can put on people's teeth. I mean, I just have a little sparkly gem. In fact, one of my favorite companies out there is launching them at Chicago Midwinter, and I'll be applying them to people's teeth there. So that's something that's pretty exciting. They've actually been out in the dental market for over 20 years, but you can get a little crystal gem of different colors, or there's these little gold things that can be bonded to, the little designs, or a little applique kind of thing that's gold that can be applied to the tooth, and people are doing it.
How long are they lasting?
So I have an informed consent that I have my people come in and sign, because I really can't make any real promises. The one that I have on my tooth is being held in place with simply bonding agent, no composite whatsoever. And so my tooth was etched for 20 seconds and I used bonding agent onto the gem. So I didn't have a lot of expectations for it. And so far it's been 3 weeks of rigorous toothbrushing and just regular function, and it's been fine, depending on where it is in somebody's mouth and also how rough they are on it. I would say it would reduce its lifespan.
I had no idea you had a tooth gem, Pam.
It's pretty new.
Wow. I thought it was like a cartoon. Every time you smiled, it sparkled a little bit.
It
That's just my natural sparkle.
I was going to say. So is there a popular tooth that everybody is wanting it on? Is it like the front tooth or like where you have it on the lower?
I think for the most part, people are going off center a little bit. So the ones I've applied have been mostly on canines and laterals. And this is my opinion, but I think the lighter colored gems are a little bit more attractive than the darker colored gems. I think like a dark blue, dark pink, your eye just goes right to them, but that's my preference. But the thing with it is, if I wanted to take it off right now, I could just pick it off with a scaler and just kind of polish any flash that's left on my tooth. So as far as I'm concerned, it's just as invasive or non-invasive as an Invisalign attachment. So I think it's definitely completely reversible and pretty simple to do, easy.
And so brushing, maintenance, home care, all that is the same?
Yeah, I mean, I've been brushing it like crazy with my electric toothbrush and everything just to see if I can unnaturally take it off. I mean, if I really wanted to, like I said, I could take a scaler and pop it off, but I've been trying to see if incising into it would make it pop off, or toothbrushing or whatever. And so far it's still hanging in there.
And is there going to be an issue? I mean, I would imagine with other like nighttime appliances or retainers, that people who are wearing those things are probably not going to be able to get a tooth gem?
Well, two things can happen. One, I would imagine that depending on the fit of the aligner or the night guard, that it could dislodge the tooth gem. Or in my office manager's case, she had like an older Vivera retainer, like an Essex style retainer. And when I put a tooth gem on her tooth, basically the gem sort of wore a path of insertion into the aligner.
Oh.
Yeah. So it sort of made room for itself in there. But I wouldn't recommend, if somebody's wearing, going through clear aligner therapy or they're using retainers or something, probably not the best idea to get a gem. Yeah.
Is there a catalog that patients can select the tooth gems from? And do you have them lab fabricated, or are they ordered from a company that supplies them?
Well, my gem, and it's being launched in the dental market in the US. It's been in the dental market for the past 20 years in Europe, is from Ivoclar. So you can get them from a reputable dental company. There are gems that you can, Swarovski crystals that you can get from the internet, and just make sure that you disinfect them and go through your sterilization process. There's also companies that will sell dental jewelry. So if you look dental jewelry up, even on Instagram, there's lots of different places that you can get them. I know one called Twinkles. There's a few other ones out there that you can get, and order your own gold applique or whatever.
And can you whiten while you have this?
I would say you probably should whiten first. And there's a couple of different ways to go about doing it. The bonding agent that's on my tooth is completely clear. So I guess if I wanted to whiten my tooth, and if I pop my gem off later, and if I had really profound whitening results, then perhaps it would be a little darker underneath my gem. But I would say for the most part, if I was going to keep this for the next 5 years, which I doubt, I would imagine that, if you were doing touch-up bleaching, it probably wouldn't really matter.
Any other things that I might have not asked about, or our audience may ask about, or they're screaming at their car radio right now?
To be honest with you, it doesn't necessarily have to fit your professional values. It was, your value system per se. However, I do think that if it's something that somebody wants on their tooth, I would much rather place it myself than have them go home and try to do it with a take-home kit. So I think from the standpoint of safety and, the fact that it's an easy thing for us to do as a dental professional, really anybody could apply it to the tooth. And also trying to encourage people that aren't getting routine dental care that are coming in for this, it's great to get them to just set foot in the office and realize it's not a scary, judgmental place. And so hopefully it'll be a practice builder for you, or at least a place where you can encourage people to get routine dental care.
How am I supposed to clean around this thing? Can I use an ultrasonic around it, polishing, all that jazz, air powder?
I would say probably you could use air powder. I would say I would definitely keep the ultrasonic off of it. It's bonding agent that's holding mine in place. So I'm sure if I wanted to pop it off, a Cavitron would do that very easily. And I think also, just like Jamie was saying with mouth tattoos, oral hygiene is really important. So and we all know that, obviously. But I think if the person doesn't have optimal oral hygiene, and if they're building up calculus on the facial of a anterior maxillary incisor, then I would say take the gem off and, and just,
We got bigger problems here.
Yeah. I mean, I feel like that's a problem. So if somebody is developing calculus around it, then probably the gem should not be there.
Good answer. So now one of the trends that I was seeing is something what the layperson was calling gum reshaping.
Sure.
Dr. Tom, I always knew that as crown lengthening. Is that essentially what it is?
I would say that the two terms could be used synonymously. So gum reshaping, crown lengthening come under this general blanket of the term called periodontal plastic surgery. It's basically changing the thickness or the shape or the position of the gum tissues to achieve either an aesthetic or functional or both result. So we do this based upon aesthetic demand for some patients. And for some patients, we work with their restorative doctors like Dr. Pam in order to create better relationships for function so that they can restore the teeth, but also not violate any biological principles.
For our listeners, because we do have some students and some new grads, like what are the biological concerns that you would do periodontal plastic surgery on or for?
Sure. So if we go into two branches here, just simply aesthetics and then look at biology, I'll actually start with aesthetics. What's the cause? A lot of this gum reshaping is done, and I think you're probably speaking about like upper anterior gum reshaping, things that we can see and that have an aesthetic component. So there are a few causes for short teeth or gums to be in positions that we don't want them to be in aesthetically, causing the teeth to be shorter. One of the things that can contribute to a gummy smile is a hypermobile upper lip. So the lip can actually, when a patient smiles, pull up really high, and that can give the gum more show. So people are more concerned about aesthetics, obviously, when they smile and they show their gum tissue. Some patients may have really short teeth on aesthetic gums, but you can't see it during conversation, so it doesn't bother them. But a hypermobile upper lip can cause everything to show. It's like pulling up the shade, and you can see everything there. So another thing that can cause a gummy smile is something called vertical maxillary excess. It's the jawbone the maxilla being in a downward and forward position. So when a patient smiles, the jawbone is actually in a lower position, and you can see a lot of the gum tissue. The tooth may be a normal size and shape. The gums may be a normal size and shape, but you may see a lot of gum tissue. And patients don't like, in general, to have excess gum tissue show, even if the teeth are of normal proportion. So when we talk about gum reshaping, usually that comes under the scope of the teeth look too short for the patient. And the usual cause of that is there's two things. One is altered active eruption and altered passive eruption. So what that means is when the tooth is erupting, the gum tissue will be coronal, or for all intents and purposes, when we're talking about the upper teeth, they're going to be below where it should be on the upper teeth. So when the gum is erupting and the teeth are erupting, they come together. And then what happens is when the upper tooth touches the lower tooth, active eruption stops and passive eruption occurs. Passive eruption is when the gum tissue retracts to its final position. So we see altered passive eruption cause this gummy smile quite a bit and cause short teeth. So what we need to do with this gum reshaping is we need to put the gum tissue in the correct position. And the way we do that is by removing gum tissue and sometimes removing supporting bone underneath. Sometimes we can get away with just removing gum tissue. But if the bone underneath is in too coronal of a position, the gum tissue is removed, it's just going to grow back. So sometimes we need to shape the gum and the bone. That's where the term crown lengthening comes into play. So if we want to do aesthetic gum reshaping, we have to have the appropriate diagnosis. And there's so many different things that we consider when we're diagnosing it. And I won't go into crazy detail here, but we need to make sure that either gum tissue needs to be removed or gum tissue and bone needs to be removed. And we can do that with a scalpel, we can do it with a laser, or we can do it with a handpiece and burst, or a combination of the three. So we can do a procedure where we can reposition the gum tissue, reposition the bone to make the teeth look a normal length and size proportion. So that's just if no restorative dentistry is involved. We can reshape the gum tissue and perform periodontal plastic surgery on it. That is when we want to move the gum upward. We can move the gum downward as well. So if patients have gum recession, we can move the tissue in the other direction. If the root is exposed, we can reposition the tissue the other way and sometimes thicken the tissue with grafting materials. Sometimes we take the patient's own tissue. Sometimes we use donated tissue, sometimes a combination. So there are a lot of different ways we can move the gum tissue up and down and thicken it as well. So that's just basically trying to get the teeth to look good. If we want to have function involved as well, functional results, and this is where Dr. Pam can kind of contribute a little bit more as well. A lot of the times we work with the restorative dentists on restoring the teeth, putting things like crowns, veneers, fillings on the teeth. The crowns and veneers can't go below where the gum is going to attach. It can't violate the attachment of the gum to the root. So normal biology is you've got this tooth root that's sitting in bone, and you need a certain amount of tooth structure for the gum to attach before our restoration starts. So if Dr. Pam goes in and she wants to put a normal size crown on an upper front tooth to make it look a normal size, but she has to go down onto the bone in order to do that, there will be no place for the gum to attach. So I need to move the bone up on the tooth to create more tooth structure for the gum to attach, and then she will put her restoration on the tooth. That's the 101 of periodontal diagnosis and options for upper anterior teeth in terms of trying to recreate the size and shape that is deemed ideal. But it's all patient to patient based.
Oh, that was great description. Do you find that people are coming in wanting that more frequently?
The way my office typically works is I receive referrals typically from other offices. So the process would typically start in Dr. Pam's office. And maybe what we could do is just kind of role play a little bit. And Dr. Pam could pretend that a patient walks into her office, or one of her patients from her regular patient pool, or someone that comes off the street during the October months looking for a tooth gem and walks into their office and starts to complain about having a gummy smile. How would that process work in your office, and then bring the patient over to my office for treatment?
So basically how that works is the patient will come to me, and oftentimes these patients are unhappy with something. Sometimes they're very specific and they can say, hey, I don't like my gum here, and what do we need to do? But oftentimes people know that there's something that doesn't look right. And sometimes it's the height of the tooth. Sometimes it is the amount of gingival display, but they're really not sure from a ratio standpoint what's wrong. They notice that something's wrong. So in my office, I start with a consultation, and then I'll take photographs. And I find photographs are helpful because it allows me and Tom to communicate really well. And then it also has the patient, gives them an opportunity to own their problem, because there's something about seeing a photograph of your tooth in front of you as opposed to looking in a mirror and just kind of seeing what you can see. So I'll start with the consult. We'll kind of have a conversation. I'll do all of my data collection, x-rays, impressions, photos, etc., and then have the patient back after I've had a chance to study all of the data that I collected. And there I will go over and just kind of give them a tour and show them everything that I see, try to understand what their value system is and what is important to them as far as what their aesthetic goals are. And then I'll then offer a treatment plan from there. And I don't even finalize my treatment plan until the patient goes and sees Tom, so that he has a chance to take a look, and then we kind of come up with a master plan, if you will, that's a multidisciplinary plan. So then I'll have my part of the plan, he'll have his part, but this way we're all communicating together.
And then Tom, you get the patient?
Yes. So Dr. Pam talks about, she'll typically send me a set of photographs. And then we always, when we're treatment planning patients, we always treatment plan to ideal. What is going to give us the best aesthetic and functional result? And then the patient doesn't always go through with it, but it's our job to provide them with our best recommendations. So if Dr. Pam sends a patient over, let's say, for example, she's planning on 6 anterior veneers. Veneers are little porcelain coverings for the front of the teeth and sometimes extend out onto the biting surface. Say a patient has malformed teeth or teeth that have broken down over time, or just wants a better look to their teeth. When we do this, if she puts veneers on teeth that don't have symmetrical gum ratios, meaning when you look at the two central incisors, you typically want the gingival or gum heights to be at the same level. You typically want the canine teeth to be at about the same level, and the laterals, incisor teeth, which are a little bit shorter, you want that to be at a more coronal or downward level. So what we do is we can talk, Dr. Pam can talk to me about how long she wants the teeth to ultimately look, how wide she wants them to look. She maybe even will provide me with a model or a digital workup as to what the teeth are ultimately going to look like. And then that will tell me exactly where I need to put my gum tissue. So then I examine the patient, I get the appropriate imaging, whether it's two-dimensional periapical x-rays, whether it's a three-dimensional CT scan, so I can see where the bone is on the facial of the teeth, which you can't really see on a two-dimensional x-ray. And then what I do is I evaluate where the gum tissue needs to be, how much gum tissue needs to be removed or repositioned, and how much bone needs to be removed or repositioned in this process. And it's typically a small amount of bone. So what happens is if Dr. Pam needs to do a set of veneers on the teeth, then she will provide me with a surgical guide. What that means is it's a little plastic suck down, and it looks like an Invisalign tray, and it will be a model of exactly what the final teeth look like. I'll put that in the patient's mouth while they're anesthetized. I will actually mark on the gum tissue exactly where the gum levels should be. And I will copy that surgical guide in the mouth. So I will trace it and I will remove the gum tissue to the point where the surgical guide tells me. And then I'll move the gum tissue up a little bit, remove the bone to that certain level, because you can actually tell how, and it's patient dependent, how far the bone needs to be from the gum margin in individual patients. It's a huge range. It's called biologic width. And it ranges from 1 millimeter in some patients to 6 millimeters in others. So it's very patient specific. So I'll know for that particular patient, I'll do my test to see what the biologic width is. And if I need the gum in a certain area, the patient's biologic width is 3 millimeters. I'll put the bone about 3 millimeters from where I want the gum margin. I'll put a stitch in between each tooth. And typically what will happen is the patient will be in a set of temporary teeth or veneers with Dr. Pam. Then the patient will heal up, and it's a long healing process for the gum to settle. It takes about 2 or 3 days where the patient has their initial recovery. They usually do pretty well with non-narcotic pain medication. Come back after a week and remove their stitches, and I say, I will see you in 10 to 12 weeks. We'll usually let the gum settle on anterior cases for about 10 to 12 weeks. Then we have them back, we make sure everything is perfect, and then Dr. Pam will move forward with her final restorations. If it's not perfect, we will touch it up. We'll do a little tissue manicure, so to speak, with our soft tissue laser or with a scalpel to make sure everything is perfect. Because the unpredictable thing in these anterior aesthetic cases is where the gum tissue is going to end up relative to the whole scope of things. The predictable thing is Dr. Pam's work, because she prepares the teeth, makes an impression digitally or analog, and then fabricates restorations. So we always want the unpredictable thing to be done and settled and checked off before we do the more predictable thing. So if we're restoring the teeth, that's kind of how we work. If we're not restoring the teeth, we do the aesthetic gum reshaping or the aesthetic crown lengthening, as you called it before. We let it heal and we just monitor the patient over time. If they're happy, we just let them move forward, and there's no restorations that are involved.
So for the people with gummy smiles that have that high lip, or that lip, like you said, pulling the curtains back, are you guys doing Botox or anything like releasing muscle to not pull as much?
That's a
what is
really
the norm for that?
So if patients have a gummy smile and their diagnosis is a hypermobile upper lip or tight upper lip, there are a couple things you can do. One is Botox, which I personally don't do. Dentists in Massachusetts can do it with just like I believe a day training course. But my recommendation would be to go see a plastic surgeon or a dermatologist who's well trained in doing this, because I know when you add Botox to an area, what you're doing is you're paralyzing a muscle for a certain amount of time, whether it's 2-3 months, and then the effects of the Botox are gone and you have to have it reapplied. So the way facial muscles work is when you have one muscle, they're kind of equal and opposite. There's muscles that elevate, there's muscles that pull down, muscles that are balanced. So if you paralyze a muscle that's an elevator muscle, that's going to make the other opposing muscle more active, and it can have an unintended consequence, which you can't reverse for 3 months. So you need to have somebody that is very well versed in oral facial anatomy that does this all the time do it. So we have a couple plastic surgery colleagues we would refer to if Botox was part of the plan. The other thing you can do is something called a reverse vestibuloplasty, and that's something I've done from time to time, but I don't do it too often. So a reverse vestibuloplasty is opposite of a forward vestibuloplasty, a regular vestibuloplasty. So a vestibuloplasty is when you deepen the vestibule in that hole. So it's the hole you put your finger up in when you pull your lip aside, essentially. So the reason we would do a vestibuloplasty is to increase space for hygiene access, to help retain a removable prosthesis so you can extend a flange down there. So a reverse vestibuloplasty is when you'll actually take the vestibule and you'll make it more shallow. And in doing so, you'll pull some of the musculature down and actually pull the upper lip down. So there's a technique where you can actually take away a lot of the mucosal tissue and reposition the upper lip. And that does have varying degrees of success. So the Botox is a temporary solution. The reverse vestibuloplasty is more of a permanent solution. But usually the hypermobile upper lip is combined with other things. So the patients will have a gummy smile, short teeth. So sometimes you can do aesthetic gum reshaping or crown lengthening, restore the teeth, and the patients are perfectly happy. Other times you have to incorporate things to have the lip come down a little bit more, like what you just mentioned. And then the vertical maxillary excess is actually a jawbone problem. So that means the maxilla is in a downward and forward position. The only way to truly correct that is to impact the maxilla, which is with orthognathic surgery, where the maxilla is actually pushed back up, which is a major surgery, which is done from time to time when it's necessary. But you can imagine if you do something to the upper like that, a lot of work needs to be done on the lower arch as well, and comprehensive orthodontics is often part of that plan. So it's going out a little bit outside the scope of what we're talking about, but just to know that it's not one thing that contributes to a gummy smile. It's not just excess gum tissue. There are all these other factors that play a role.
No, that was great. Is that what they used to call a lip flip? We did it in my perio practice like 12 or 15 years ago, but they always called it
They were doing lip flips there. I'm not sure. That could be it.
I can't imagine. I'm like, I can't even remember what it was.
Being used for anything else. Have you ever heard of that, Pam?
No, I've never heard of a lip flip.
You could do a lip flip to show off your mucosal tattoo.
Yeah, right. Just bring it down. I don't know what little thing that trend is out there right now where you're like gluing your upper lip up higher. Have you guys seen that?
Are they pumping their lips just too much full of whatever it is they're putting in there?
Hyaluronic acid, whatever they're doing.
Looks
This is like
pumping them up with a bicycle pump.
Yeah, they are. They're getting kind of big these days. But there's some kind of trend you'd have to look at. It's somewhere on the social media, and it's some kind of glue, and they're putting it like right here, and then you hold your lip, and it stays. Maybe by the time this comes out in my intro, I'll give you guys what the name.
Sure, we all will be looking at each other with a glazed look in our eyes because we'll know what's going on once we research this.
Someone even did it on a news show. Oh, I'm gonna find it. I'm gonna send it to all of you.
Please do.
And then y'all are gonna be like, "What?" I don't know why these things pop up on my Instagram feed. I really don't look at weird. Most of mine is dental, and then these strange things pop up. Okay, so the last thing that I was curious about was filler in the papilla to restore those black triangles.
Mm-hmm.
Is that something that's trendy right now, or that was like an older thing and now we saw that wasn't working out so well?
Sure. So people are doing it. Again, it's a temporary fix. So it's trying to rebuild papilla that have been lost is been something that people have been chasing with different techniques and methods for probably decades now, well before I've been in practice. So one of the latest trends is to put what's called dermal filler into the inject it into the papilla. And it will cause the papilla to swell up a little bit. And the dermal filler will sit there for a certain amount of time, but it will eventually shrink down and go away. I'm not opposed to not me personally, but to sending to a plastic surgeon that might be able to inject dermal filler to plump up a papilla if nothing else absolutely works. Basically, the problem with black triangles is that typically they're caused by bone loss in the area. So bone loss in between the teeth, but the bone supports the papilla, it supports that tissue, especially if the teeth are farther apart, because there's more of an amount of tissue that needs to be supported. So sometimes we can push the tissue coronally back down on the upper anterior teeth by moving the teeth together or shaving the contact down and allowing us to move the teeth together, or actually orthodontically erupting the teeth, pulling the teeth down so that the bone comes down. But it's a highly complex process because a lot of times the teeth need to be restored. We've tried soft tissue grafting procedures to plump up the tissue with grafting materials such as patient's own tissue, dermal matrices. But oftentimes, I can't stress enough that the bone supports the tissue. So if you don't do anything to change where the bone is, it's eventually going to relapse. I have that discussion with my patients over and over again. If we can't change the position of the bone, ultimately, whatever you do is not going to be successful. And it's been proven through the literature for years and years, and people are trying these techniques, and some have worked better than others, but the unifying theme is that they're temporary. So I think the same with the dermal filler. I think it's temporary. If you can commit to getting your papilla injected at certain time intervals and you want to spend X number of dollars, probably $500 to $800 per injection, because the filler is actually very expensive. If it's that important to you and you can maintain it, then go for it. There are alternate methods, and also Pam can talk about maybe some prosthetic methods to fill in the papilla if you want to do a quick commentary on that. But the dermal filler is becoming more prominent and popular, but there's not a lot of high-level research on it yet. I'm sure that's in the works. In fact, I know a couple of people that are working on some projects right now. So to be determined. When we do this again in a year, we can talk more about it.
See what the trends are in 2021.
Exactly.
Before Dr. Pam gives us her thoughts on the restorative stuff, I would like to say that I'm not a crazy person, that this is called the challenge involves using eyelash adhesive on the upper lip and then pressing the top lip up to give the appearance of a plumper look. A viral challenge has people on TikTok plumping their lips with lash glue.
Wow, your research team is good.
Last viral challenge, weren't people eating Tide Pods?
Yes, they were. This is why you don't do anything that's viral. But it was a TikTok challenge, and this is why I stay off of TikTok. Okay, I just wanted to make sure I wasn't a crazy human.
No, you're not at all.
Okay, Dr. Pam, what are some of the things that people are doing for the aesthetic issue concern of the black triangles?
Well, first things first, I have lash glue that I'm going to go upstairs.
Should we do this? And
I thought I saw you applying something to your upper lip here.
I know.
I'd be like, I just need to see.
This also said super glue, and I just think that that's a tad bit crazy. Like lash glue, all right, I get it. That goes on skin, I get it. But
yeah, no, I would definitely,
come on, guys.
Yeah, avoid the super glue. Anyway,
but also avoid eating Tide Pods. So,
all
good advice here.
This program does not condone eating Tide Pods.
Yes,
it does not. I'll put that in the show notes.
That's so
sorry,
funny.
Dr. Pam. Go ahead.
Okay, so black triangles. There's a lot of things that we can do restoratively, and you don't have to always be super invasive about it. So again, it comes down to appropriate treatment planning. What part of the tooth is exposed? Is the tooth exposed versus the root is exposed? And how much black triangles is exposed? If there's really large black triangles, you can always try anything with composite. Whether it's going to hold up or not, we don't know. But it depends on the patient, their risk factors, their oral hygiene, etc. But you could always try it with composite. You can always go back later and consider something like a veneer or a crown or something like that. But it really does come down to appropriate treatment planning. So I can't stress enough how important photographs are. And oftentimes when it comes down to moving forward with this kind of modality, I will create a diagnosis. I'll take models, and you can create a diagnostic wax up, whether it's in a lab or with digital. And then I usually have the patient try it in with some sort of mock-up, so that I haven't drilled on their tooth, I haven't bonded anything, and just have them see what it looks like and see if that's exactly what they're looking for. And then once they say, yes, absolutely, this is what I want to do, then there's options for you, whether it's indirect, veneers, crowns, etc., or something that's direct with composite. And I can tell you that both treatment options are very successful to close a black triangle, provided they don't get more recession after.
Yeah. Well, this has been very informative. I thank you guys so much for coming on and chatting about the trends of, I guess, is it trends of 2019 or would this be trends of 2020? I mean, it's February. I don't know how that works.
We've got to be
Not
more
really
progressive. Trends of 2020, I think, would be appropriate.
Yeah. Well, yeah, you're right. Because you never know. Tooth gems and mouth tattoos, they might become more popular now that we've talked about it.
Especially after the show.
Definitely.
Exactly. So I would love everybody to give their contact information if you would like. So if anybody has any questions or they want to visit your practice or even your, tattoo shop? Like what do you call this?
Parlor, right?
Yeah.
Parlor? Still?
Tattoo
Okay.
shop.
Tattoo shop?
Yeah.
Okay.
Yeah.
All right. Jamie, where can we find you?
My shop, Forsaken Ink, is located in Milford, Pennsylvania. Or if you want, you could go on Instagram. My handle's at Jamie Henderson Tattoos. And I can answer any emails and set up appointments through there.
Awesome. Dr. Pam?
I'm pretty findable. My office is called Salem Dental Arts. So I have an office website and a Facebook page. You can find me on Facebook at Pamela Maragliano-Muniz and on Instagram on Dr. Pamela_Maragliano.
And today's Dentistry IQ.
Oh, yes. Well, you can always find me on dentistryIQ.com as well.
Yippee. I'm so glad you're back.
Yay,
and Tom?
So my office is called the Perico Group, and the website is thepericogroup.com. I can be reached at, I'll give you my email, twsperico@gmail.com with any questions or concerns. Hopefully there's not too many concerns. And we have a Facebook page as well for just search the Perico Group on Facebook.
Awesome.
I'm sure we have an Instagram page, and I don't have a personal Instagram account, which I will change eventually.
You do have an Instagram page, so if you find mine, you can see who I'm following, and I follow you guys.
Rock.
Instagram's way better than Facebook, I can tell you.
Oh, without a doubt.
Don't tell Mark Zuckerberg that. He's been listening, I guess.
Yeah, this podcast is that popular that Mark listens routinely. Well, thank you guys so much for taking the time and coming on. And I'm sure our listeners are very excited to share any information with their patients. Or if the next time they see a mouth tattoo, they're going to be like, I know all about that. That's very trendy. Where did you get it? And obviously it was done really well because it hasn't become a blob. So.
That's the determining factor if it's done well.
Exactly. Not a blob.
Pretty much.
All right. Well, thank you guys. I hope to have you back on one day as well.
Thank you guys. Anytime. Good talking to you.
Thank you.
Pam, I'm sure I'll see you soon.
I will. It was a pleasure. Thanks, Michelle.
Well, I love round tables. I do. I love them so much because, and especially ones where we bring in non-dental people and we talk about random things. We mentioned our tattoos. Like, it was just fun. I love it. I wish I had a glass of wine when I was doing it, but oh well.
I'm surprised you didn't, actually.
Well, I had just driven in to Greenville, South Carolina, because I was giving a presentation the next day. So I was in my hotel. I barely made it on time. So you guys got that part and a go-to meeting side of it. Sorry about that. I know the audio wasn't as great as we always like to do it, but we tried to make it happen. So I hope everyone enjoyed this. Feel free to reach out to our guests. They're always so awesome and are willing to answer your questions and talk to you guys. And if you're not already, we'd love for you to follow us on Instagram and Facebook. And you can head over to our website at taleof2hygienist.com and sign up for our newsletter. We give one out every month. And then we're also doing some awesome giveaways. If you haven't already listen to some of the tip episodes, go ahead and do that and head over and sign up for our email list, because then you'll be able to get some of these awesome giveaways.
Have a great week, everybody.
Yeah, we'll see you next week. Bye, y'all.